welcome to the afternoon session, 2:45. First comment, Bernardo Cortese, he's not here. He's got a viral condition called COVID. Yeah, that's very strange. I thought that was a few years ago. Let's call up the panel, please. Doctors Lulic, Rathore, Prvulovic, Okutsu. I shouldn't have started that, should I? Chiwane and Iakovou. Please come up. Right, everybody's still having a cup of tea. And we're going to ignore that. I haven't seen Shao-Liang Chen yet. Okay. So, thank you. So, we're very lucky to have Shao-Liang Chen talking to us about his DCB study. This is going to be a very interesting and potentially controversial session. So, I don't know, I'm going to look at the IT crowd and say, have we got a link to Shao-Liang Chen? We do.
Hi, David.
Shao-Liang,
good morning.
How are you doing?
Hi, how are you doing? I'm doing very well. Thank you. Once again, congratulations to the success of EBC meeting in Warsaw. I cannot be on site to meet all my friends. Also, I thank the organizing committee to invite me to present the rationale design and the current status of DCB bifurcation trial. This is our new bifurcation trial. So this is a study flowchart. I tried to simply summarize the study design. So at the beginning, so the patient should be in true corner bifurcation defined by Medina 111, 011, or 101. But the side branch diameter should be minimal 2.5 millimeters, and the lesion length must be shorter than 10 millimeters by visual estimation. So following the step provisional standing technique, so we need to wire the main vessel and side branch. After standing main vessel, after port technique, if the osseous side branch lesion length greater than 70%, so the patient will be randomized to provisional standing with NCB conventional non-compliant balloon group compared to provisional standing with DCB group. So basically, after port technique, so in both groups, we need to use a NC balloon to dilate side branch. But in DCB group, after NC balloon inflation, so we need to use the DCB to dilate side branch again. After dilating side branch, we have to do kissing balloon inflation with NC balloon in both groups followed by final port technique. So after balloon inflation, if TB blood flow less than 3 or the presence of type 3 calcification in the side branch, so additional side branch stent is recommended. So in general, for this trial design, we have to enroll simple bifurcation lesion according to the definition criteria. Standing main vessel, then NC balloon inflation or DCB balloon for side branch. This is a multi-center randomized clinical trial. Before the design of this trial, we need to know, should we pre-dilate side branch before standing main vessel or dilate side branch after main vessels is standing? So this is a test to measure how many particles scratched from the DCB from the balloon. So the left figure, you can see most of the particle diameter is less than 3 micrometers. On the right panel, you can see if there is standing in the main vessel, so crossing the DCB into the side branch would increase much more drug sound from the balloon scratched by the metal stent struts. So finally, you can see the number of particles greater than 1 micron increased by more than 50% if there is a stent in the main vessel. So finally, I decided we have to follow this provenous stenting technique. After stenting main vessel, we can use the DCB for the side branch. This is the organization of our trial. So the primary endpoint is a MACE at 1 year follow-up, including cardiac death, myocardial infarction, or the clinical-driven TAR. Secondary endpoints including all-cause death, myocardial infarction, revascularization, including either TAR or TVR, incident risk stenosis, also crossover rate from 1 stent technique to 2 stent technique. Safety endpoint is a stent thrombosis. This is a calculation of sample size. Basically, the assumption is that in provisional stenting with NC balloon group, so the 1 year mass rate will be 17%. But in the DCB group, it will be 10%. So finally, including 10% loss to follow-up, so a total of 784 patients was required. So these are the general requirements of inclusion criteria: Medina 011, 101, or 111 true coronary bifurcation lesion, side branch diameter minimum 2.5 millimeters. But the key point is that side branch lesion length should be shorter than 10 millimeters by visual estimation. And also, after stenting main vessel, they also show side branch stenosis should be minimal 70%. So let's go through one case. This is tissue left main Medina 111 true coronary bifurcation lesion. So we wire the RID diagonal as well as flash. So after stenting main vessel from RID to left main with an jet wire in flash. So after stenting main vessel, we perform sequential port technique to make sure the full expansion of the stent. After port technique from the apical, you can see osteosen flex stenosis greater than 70%. So the patient was randomized to our DCB bifurcation trial. So firstly, we use NC balloon to dilate the osteosen flex. So after the NC balloon dilation, we use a DCB, a long DCB, to dilate the whole lesion length from the sun flex to the left main. After DCB dilation, we perform the final kissing followed by final port. Even still, there is a compromise as the osteosen flex, but it looks much better. So finish the procedure for this patient. Thank you very much. Thanks for your attention.
That's great. Thanks very much, Shao-Liang. Stay with us for a few questions. And just a show of hands, if you can, from the audience, who currently uses drug-coated balloons in the side branch ever for bifurcation? Oh, the word ever prompted some hands. Okay, fair enough. Some questions, any questions from the panel for Shao-Liang about this interesting study?
Do you have any protocol for predilatation of the side branch? Precise protocol? How many inflations? How many times do you use any scoring balloon? And what are the criteria for successful predilatation of the side branch?
Yeah, it's a good question. According to the provisional stenting technique before stenting main vessel, so we do recommend to predilate the side branch using scoring balloon, cutting balloon, or any other devices. After main vessel, stenting main vessel, I think it will be not easy to use a scoring balloon or cutting balloon for side branch. So we only recommend to use the NC balloon to dilate side branch before DCB. Thank you.
What is the criteria percent of the residual stenosis after the predilatation? If you
70%.
have to bail out stenting of the side branch, what would % of acceptable residual stenosis will you define? What will you define it?
Yeah, I think I can show this slide again. Can you see my slides? Actually, after dilating side branch, if the side branch TME flow less than 3, or if there is a type 3 dissection in the side branch, we will deploy the additional stent in side branch. So it's independent of the side branch diameter stenosis.
Great question from the floor.
One question, Dr. Chen. You said that the side branch length stenosis should be less than 10 millimeters before we include them in the study. But the case that you showed, the drug-coated balloon looked like much longer, looked almost 30 millimeters in length. And not only that, after that, we use a short balloon to do a kissing balloon dilatation. I mean, don't you think that would influence the way in which we're going to do something about the side branch? Because we're putting in a long balloon and then inside that a short balloon in a dissected segment. After all, a balloon is a controlled dissection. So is there some subgroup in which you're going to look at the length of the balloon that we use, the DCB that we use in the side branch?
A very good question. This case was not included in the DCB bifurcation trial. Basically, we tried to include the patient in the trial, but as you say, because we didn't have the short DCB balloon at the same time, so finally we did not include the patient in the trial. In China, before the initialization of this trial, we didn't have short NCB balloon. So minimal DCB balloon length, I think, will be 15 millimeters. So for some cases, it's not easy to use it. It's not good to use long DCB for the patient.
Hi, Shao-Liang. This is Sudhir here, Sudhir Rathore. Could you just expand more on your sample size calculation? Like you said, primary endpoint of 17% versus 10% in DCB and NC balloon usage. So is that based on combined endpoint of cardiac death, TLR, clinical TLR, and MACE events, or?
Yeah, thank you, my friend. Actually, the primary endpoint is 1 year MACE. So according to our previous DKQACI-2 trial, which included all bifurcation lesion. So from that study, we extracted the subgroup for patients with simple bifurcation lesion. I mean, the side branch lesion length shorter than 10 millimeters. And also we calculated the 1 year MACE rate. Also, we have our DKQACI-7 trial. Also, we get the 1 year MACE rate from these 2 trials. So finally, we estimated the 1 year MACE rate in the NCB group will be 17%. So finally, I think this calculation, this estimation is very similar to the EBC main trial. But EBC main trial is only for distal left bifurcation lesion. I think it should be a little bit different. This is the reason why we calculated the final sample size was 784 patients. Thank you.
Thank you very much. Two last short questions, and then we're going on to the next session.
Hello, it's Olivier. A question, your DCB is plaquette acceleluting, and if you put a second stent in the side branch which had the DCB before, what would you put in terms of drug or bare metal or drug eluting also, but a different drug? What do you put?
Yeah, exactly. For this trial, palitazole-eluting balloon is only available in China. So after DCB, if we need to deploy a second stent in side branch, there is only one choice of using sirolimus-eluting stent. So I think this is a combination of different drugs from DCB and also from stent. But from previous animal study and also clinical trial, there is no any conflict report about the side effect of the combination of the paclitaxel DCB with the sirolimus eluting stent. Thank you.
Any last one?
Kushan, just wanted to ask a question, because in this we are only treating the side branch after we've already implanted a main branch stent. So do you think that calcified lesions can be enrolled in this trial, because we don't have an option of using cutting balloon or rotablator if it is a calcified ostium of the side branch, even if it is a short lesion?
Yeah, very good question. Because my presentation is very short, I think I could not very clearly present the study protocol. Also, we have many exclusion criteria. For example, if there is greater than moderate or severe calcification inside branch, patient should be excluded. So actually, for simple by true coronary bifurcation.
Okay, fantastic. Thank you very much indeed, Shao-Liang. The music's slowly getting louder. So we're going to move on. Franz Kleber is going to come and talk to us about the current evidence supporting DCB use. Franz.
Thank you very much, Chairman, ladies and gentlemen. I think it's wonderful that the DCB and the EBC world meet here. And I think I'd like to thank the organizers for inviting me. I have no conflicts of interest. So actually, treatment of bifurcations with DCB is far more than 10 years old, and still we don't have a lot of data, really. What was the reason why we really got into bifurcations? Well, one reason, we have less or no carina plug shift with a balloon contrary to stent. We have positive remodeling of the ostium of side branches. We have the easiness of the procedural workup, and we have good casuistic cases. So let me introduce you now through the history of this development, what we have. We don't have a lot, I have to say. This actually is a case I presented 12 years ago at the Asia PCR. You see the LAD D1 bifurcation with late follow-up. One of the first studies was done very early when we had instituted the, at that time, German drug-coated balloon group, and did the first consensus paper. This was a study with the DCB in main branch and side branch, and a BMS in the main branch. At this time, we thought that the combination of a DCB and a BMS would give a good result. You see the result in the side branch, where only the DCB is quite good, and the main branch is not as good. Then the debut study was performed. Problem of the debut study was that the DCB was without an excipient, and you see three groups, one with the DCB, and one with the bare metal stent, and the third one with the DS, and the DS was better than, of course, because this was basically similar as a regular balloon. The next study I have to mention is the Babylon trial. Here you see a bare metal stent again with the DCB in the main branch and side branch, and the DS in the main branch. And what you see here, if you go through the data, you see that the side branch restenosis rate, the DCB group is quite good, while in the main branch there is the DS is better off. Then we have the study by Rathore, not randomized, 50 patients in each group, serially performed. And basically what we can compare is the DCB in the side branch versus POBA in the side branch. And here you see a huge difference, both in MACE rate, as we just heard, 11 versus 24% MACE, and late loss 0.09 versus 0.4. So in the side branch, much better results with the DCB. Then the study Biolux 1, and again we look here at the late loss in the side branch, 0.1. Again, a good result in the side branch with the DCB, and this was for the first time a drug-eluting stent, not a paclitaxel, but a limus-eluting stent in the main branch. So this was a step from BMS to paclitaxel-eluting stent to limus-eluting stent. Very similar Sarpedon study, also a low late loss in the side branch with the DCB, similar procedure. And then we have the Chinese study by Qing, Beyond study. And here we have, again, the DS in the main branch and the Bingo PCB in the side branch. Astonishing to me that they had really Medina 111 in about 90% of the cases. Hard to achieve, really, but they had a lot of cases. And the major endpoint was QCA, target lesion stenosis, 28 versus 40%. All differences highly significant for the side branch, similar as in the other studies, but this now is a randomized trial. You see diameter stenosis 22 versus 34, late loss here for the first time, a minus late loss, so a late lumen enlargement in the side branch versus 0.18. And then we have the depth side study with a dedicated bifurcation stent, the NIRPAC stent, and the PCB in the side branch. And again here, a negative late loss of 0.04. So this goes basically through the studies, as you see. And then we have the first observational study, actually from my group. Antonio Schulz presented this data with DCB only in both branches. And you see here in the side branch, which we look at here, again, 3% restenosis rate, and the distal main branch 6.6%. Then we have the registry by Leonhard Bruch, also a former co-worker of mine. He presented 127 patients. A little more than half of them had bifurcations, 53%. And for this group, the DCB only group really showed good results, as you see here below. Actually, oh, sorry for this. You see here, this is the DCB only group, and this is the DCB group plus stenting, DS stenting. Then we did, in my group, the first small randomized trial, DCB versus POBA in the side branch. The Medina 111 were excluded, so the main vessel was excluded. Some of the investigators were worried at that time, and you see the MLD was similar. Follow-up was, the MLD was better. At follow-up, late lumen loss was considerably different, and binary restenosis rate 6 versus 26%. I think this is from the data I showed you now. Every study showed the same. This is now in a randomized trial. I think the side branch DCB is clearly better than a POBA in the side branch. So, to the next. And then I think this is a very important small mechanistic study by the group of Dr. Shin. Her published this data, and they basically used the DCB only in the main branch and looked by OCT how do the side branches behave. And as you see here on the left, this is the early result with the dissection, and you see this is the ostium of the side branch initially, and after 9 months follow-up you have this opening of the side branch, which is clear. If you open the vessel by the drug, if you have positive remodeling, also the side branch has to open up, and she could really show this very, very nicely. And this is here more downstream in the side branch vessel. I think this is a very, very important study to show that you don't have necessarily to touch the side branch, really. And this is again from her data, because you see the mechanism here in the main branch. You have the initial improvement in lumen, and then it continues further due to the drug. And in the side branch, you don't have the dilatation, but you have the improvement in lumen caused by the drug, which is there at the side branch ostium, and actually the side branch luminal area increases quite considerably from 1.0 to 1.4. Yes, I think this is about what we have. This is a bifurcation we did with long DCB application, 7.7 centimeters overall. You see the late follow-up. We actually did the late follow-ups earlier than usually, already after 4 months, because from the pathology standpoint, and I talked to Reni Vermani about this, nothing happens anymore after 4 months of DCB only application. So let me briefly summarize. DCB in bifurcations is a promising and established technology. DCB, having been around for over 12 years, has still a shortage of data, a huge shortage of data. DCB in side branch and DS in the main branch is more widely proven than other technologies and more widely accepted. The DCB with a bare metal stent is no more in. We should not do that. And the DCB sequentially applied makes bifurcation treatment more easy. And I think that positive remodeling and less or no carina and plug shift are the determinants of the beneficial effects of DCB. Thank you so much.
Fantastic, thanks. Let's open it for discussion. I'll start. What happened since 2016?
Too little, as you see.
Yes. Why?
Well, there, of course, are some data from large studies with subgroups, but I don't think that subgroups bring us any further. I think we really have to have dedicated data.
I agree with you. There was this meta-analysis from Megali and collaborators from 2018, and they only included basically 4 trials at that point, and it was in 2018. And up to this date, we don't really have a lot more randomized trials.
I think the data is so scarce and it is so fudged up that probably the questions are also not going to come up, because I think the usage is so low. It's just anecdotal. Predominantly, you use it for our understanding probably of drug-coated balloons comes from restenosis, instant restenosis, where you know that it performs well. Extrapolating that data to side branches, to main vessels, to left main bifurcations, I think, I mean, if you believe in the fact that you're not going to leave any more metal in that bifurcation if you're going to use a DES, a drug-coated balloon, sorry, nothing beats that. I think.
I don't agree that the data are anecdotal. There is a number of centers which just uses the DCB as default, and this for 10 years. And if it's so bad, if it's so anecdotal, it wouldn't be like this. But I agree that we have to do a proper study for this. This is correct, and I think then we have what we need and want.
Yeah, I kind of agree with it. Yes, because when we had a show of hands, everybody in the audience have used drug-coated balloon in bifurcation setting, despite being any solid like randomized controlled trial or a clinical trial. And it does make sense. Obviously, we don't have data because we have not conducted a randomized study, proper randomized study, which is relevant clinically. Because obviously, if it's a small side branch, you won't be looking for mortality benefit and things. So I think it has to be done in a large side branch, left main setting. There it will have impact on TLR and clinically driven TLR and myocardial infarctions. And even if you avoid 2 stents, reduce stent thrombosis and mortality reduction as well. But we need to test it as a hypothesis.
I agree, not for the side branch only. The side branch only, I think, is clearly shown in two randomized trials. We don't need anything for the side branch, but we need for the procedure itself. Do we need a DES in the main branch, or should we not use a DES in the main branch? And what does this to the bifurcation and to the plug shift and all these things? I think this is important.
Question from perception. Do you have some specific data regarding the type of the side branch for which you use the DCB? Will that I mean, the size, was it proximal, ostial, and proximal? Other data, because if we generalize for all side branch DCB, I think we will not, the data will be diverse. We need to know more details, which side branch you promote for the DCB better than second sense.
I think what we learned is that the ostial side branch has a clear benefit because it also has the drug from the main branch. If you have long lesions in the side branch, I think they will behave like other small vessels.
Okay. Thank you so much. And I would like to introduce Simon Eccleshall, and he will speak about the need of IVUS more or less during DCB treatment.
Great, thank you very much. My name's Simon Eccleshall from the Norfolk and Norwich in the UK. That's the title of my talk. Do we need IVUS more or less with DCB treatment? So my personal view is less. Currently we use it very rarely in our centre and we do an awful lot of DCB work. I guess we better look at what data there is out there, and actually, a bit like in the last talk, there isn't much. So, imaging and DCB. Well, imaging we know for stents is really important to plan the procedure, tell you how you've done your lesion preparation, and then optimise the stents afterwards. It may be helpful for in-stent restenosis and is strongly advocated in the further treatment of it, particularly identifying the cause of stent failure. Franz has just told you about late lumen gain at the ostium of the side branch, which I think is particularly pertinent here for a bifurcation discussion. And yeah, it's all about main branch DCB really. So what else is there out there about IVUS in the study of DCB? Well, there was a retrospective study of cases from 2014 to 17 published by Konishi. 900 DCB cases, 240 were de novo, only 188 were eligible for their retrospective analysis. Essentially using lots of good lesion preparation, what they showed that target lesion failure was predicted by a residual plaque area of around 60%, and that seems to run through some of the data that we'll see in a minute. So there is one study that I could find which is looking at the use of IVUS versus angiography to guide drug-coated balloon in de novo vessels. It's called Ultimate 3. It's in high bleeding risk patients. It's between IVUS and angio guided for de novo with the sequent please balloon. 7-month angiographic follow-up with the primary endpoint of late lumen loss, secondary endpoints at 6 months. As far as I can work out, it's still recruiting. So what about IVUS guiding balloon angioplasty rather than DCB? So we're now going back about 20 years. In 2000, it was shown that if you use IVUS, it promotes larger balloon size. Larger balloon size means more vessel dissection. And the IVUS criteria for dissection grades from none to a partial tear to 50 cent plaque diameter into the media with secondary lumen were not predictive of early complications or late restenosis. In 2002, there was another study showing that MACE with residual dissection was again predicted by IVUS area stenosis for around 60% or more. And then more recently, but still 20 years ago, the BEST study looking at aggressive IVUS-guided balloon angioplasty. They were so aggressive that they had to bail out in 44% of cases, and they were bailing out for flow-limiting dissection and greater than residual 30% residual stenosis. That's on angiography. And IVUS greater than 30% area stenosis or less than 6 millimeters squared MLA. There was no difference in TVR, but in those that were stented in the balloon group as compared to the stent group, there was a lower restenosis rate, which would suggest that if you do really good lesion preparation, your stents do better. So because there isn't much out there, I thought I'd share a little bit of our data with you. I alluded to this a bit last year. We've been working on the data a lot more since. So we've got between January 2015 and November 2019, over 2,000 bifurcation lesions as defined by EBC ARC criteria. We're a big, what happened? Oh, thank you. We're a big DCB centre, and within that 2,100, just over 1,000 were DCB only. That's main branch, side branch, everything. And of those, only 3% used intravascular imaging, which is why it's pertinent to this talk. Just over a little bit more, 1,080, was a stent-only strategy. We removed any that were hybrids. We then propensity matched them down to just under 1,000 in each arm, which tells you already that those big groups are very closely matched anyway. So we propensity matched 1,996. The median vessel diameter of the largest device, stent or balloon, was 3.5. So this is a big vessel cohort. 20% were true, as in complex bifurcations. We got the data in a number of ways. We linked to NHS Digital for death. We get what's called HES data, which is hospital episode statistics, which is every episode that the patient is admitted to hospital is coded with diagnosis and any procedures. And we also get NICOR data, which is National Institute for Cardiovascular Outcomes Research. Every case that we do in our lab, in every lab in the UK, has to be reported to the national body. The national body then feeds into NICOR. So we know if our patients end up anywhere else in the country having a further revascularization. So the composite endpoint, bifurcation composite endpoint for long-term follow-up of these propensity matched patients, as you can see, show a significant benefit to DCB as compared to stents. The p-value is there for you to see. Within that, it's mostly driven, interestingly, by TLR, with an increasingly significant difference between the two. We've actually did a landmark analysis because somebody suggested we did it, and the interesting thing is that it's virtually all late TLR, and actually in the bifurcation group, it's virtually, in the DCB group, it's virtually a flat line after the first year, and this is something that comes through in some of the other studies of DCB de novo work. After the first year, you've got that tiny attrition rate because you have coronary artery disease, but you don't have that attrition rate because you've left a stent in there. Sensitivity analysis suggests that most of the benefit actually is in the more complicated bifurcations. So, and that was all with virtually no intravascular imaging in our balloon group. This is a case of mine that I found that where we did use IVUS, and the reason why we used IVUS, as you can see, top left, a rather complex but very big left main stem. We used IVUS to tell us that actually the left main was 6 millimeters, the LAD was 6 millimeters, the ostium of the circ was okay. So all we did was drug-coated balloon angioplasty, left main into LAD. Didn't need to treat the circumflex. So top left is pre. Hopefully you can spot that that's worse than the others. The middle one is immediately the end of the procedure. And the way we did it was the largest scoreflex balloon we could find, which was a 4.0, the largest paclitaxel DCB that we could find, which was a 4.0. It was a very underwhelming result. So unusually we post-dilated it with a 6 millimeter non-compliant balloon. Far right as a 3-month follow-up, again showing late lumen gain. So that's one way you can use IVUS in your DCB de novo work. Some of you may have heard of the solution study. This is a case that Andrew Venisis from Nottingham has said that I could share with you. This is from the solution study, a patient randomized, obviously, into the solution drug-eluting balloon arm. Here's Andrew doing some lesion preparation in an LAD. It's a big vessel. These are 4.0 and 4.5 balloons. Rather nasty looking dissections there. Don't know whether people feel that those are ones that you would accept or that you would need to stent. So to my mind, in this, there's essentially two bits to look at. There's the LAD diagonal bifurcation. On the top of the LAD, there's a dissection. The contrast there is clearing. The other dissection is at the ostium of the LAD on the underneath in this view, and you can see the contrast is tracking back into the distal left main stem. So that's one view. There's another view. So the distal dissection now looks a bit more complex, but again, all that contrast is still clearing and it's TIMI3 flow. The one at the top in the distal left main stem, however, there's some contrast that's tracking back towards the left main stem. and seems to be persisting. So persistent contrast, generally, you're told you shouldn't accept that and you should stent it. Another view. What do people think? Stent it or leave it? So what Andrew did, because he's a very keen imager, he used an IVUS. And I asked him afterwards, tell me about the IVUS criteria for this, because I wasn't aware that there were any. His reply was he used OCT criteria for leaving dissections at stent edges. And he decided, based on this IVUS run, although there is extensive dissection, none of it fulfilled the criteria to require stenting. He didn't stent it. The patient, according to him, has done very well and remains in the study. So, in conclusion, de novo DCB is still a work in progress in its own right, and there are big RCTs out there now. Intravascular imaging is important in PCI, particularly in the context of stenting and scaffolds. It's not yet found its place in DCB-only PCI, and we shouldn't forget physiology as well. Thanks very much.
Thank you so much. There are some questions. Eve? Oh.
I have seen recently, it was last week, a presentation by Antonio Colombo. He was piloting the procedure of DCB only with physiology, FFR. Have you the experience of this instead of IVUS or OCT?
I know Antonio is very keen on using physiology, particularly to predict dissections that can't be left. Anecdotally, I've seen a few. Generally, we don't actually work on the pressure wire for our DCB angioplasty because we're not good enough operators and the wires don't behave very well in our hands. So we use pressure wire a lot to decide if we're going to fix, but then we work on a normal wire. So I don't have much of my own experience of it. Generally, if we do have it in and we're looking to see a result, to my mind, all you need to do if you're doing DCB-only angioplasty is turn a vessel that is ischemic with whatever parameter you're using to non-ischemic, and then you rely on the late lumen gain as long as it's a safe result.
So in 1981, Grunzek did 3 balloon PTCs of the left main at Emory, 2 of them died. So it's somewhat cavalier just to leave balloon and left main and not stent it. And because there is a risk of sudden death, even though the left main is large. And I think I'd be very wary of doing this without a stenting procedure, even though it's with a large stent size are available now. Is this just historical? You just don't balloon the left main and leave it alone?
We do, and there are published series now showing safe results.
Most interventionals will not do it.
The last case that you showed, the clear-cut spiral dissection from the ostium of the LED, and it stopped at the bifurcation. So, I mean, the gentleman said that patient is doing well. I think most of us would stent it. So it will be very interesting to show this gentleman's follow-up, say 4 months, 3 months. I would just say the entire dissected segment would have healed by 1.5 months. Just do an IVUS at 1.5 months, 2 months, just to see how things are. So even if there's a 60% narrowing, he would still be asymptomatic.
So if you have a dissection, your restenosis rate is lower than if you don't have a dissection on angiography after balloon angioplasty or after DCB. Because the dissection, as long as it's a safe dissection, is telling you that you've done an adequate lesion preparation.
So I agree with you. The dissection here appeared to be a spiral dissection, which if you follow the basics, these spiral dissections get worse, number one.
Sure.
Secondly, your injection, your injection makes the dissection worse. So just very low pressure.
I'm sure there are people in the room a bit like us that have done an awful lot of DCB angioplasty, and you don't make iatrogenic dissections from balloon angioplasty worse with injections, except those that are already vessel-threatening dissections that you need to stent, and those you just need to get on and stent.
Just a couple of short questions.
Just learning from Dr. Colombo, as we have so many here. So he says that decision to use a DCB should be after the pre-dilatation. So if you have a good pre-dilatation result, you can think about DCB. So why should a trial not be designed where we randomize after the pre-dilatation? So you do a pre-dilatation, if there is a good result with no dissection, good lumen gain, then you randomize to the DCB arm versus a DES arm. Because sometimes in these trials, we see patients where DCB is going to fail. There is long diffuse calcified lesion and it gets randomized to the DCB arm. Why not randomize after pre-dilatation to a DCB versus DES arm?
Simon, just
I think I kind of.
So the answer to that last point is, to my mind, there are essentially two ways of doing RCTs for DCB against stents. The first one, which has been used more widely, is the one that you're alluding to, which is that you do good lesion preparation. If the lesion preparation isn't good enough, they're out of the trial and they get stented and they can be in a stent registry. If the lesion preparation is good enough, as per the usual consensus guidelines, then they're randomized to either a DCB or a stent. And I would call that device strategy randomization. The alternative, which hasn't been done much yet, but has been done in some studies or ongoing studies, is what I'd call strategy randomization, which is you take your pictures, you decide you can do everything that needs to be done in that patient, either with stents or with DCBs, then they're randomized, and they're then randomized to one arm, and they have to stay in that arm. So if they're in the stent arm, everything gets stented. If they're in the DCB arm, everything gets DCB'd unless you have to bail out on a specific lesion, in which case you bail out on that lesion, the rest of the lesions remain in the DEB arm. So there's two different ways of doing it. It's either strategy or device.
Very last one, Adelaide.
Okay, so mine is a question just to try to understand the mentality. It's me, look in front of you. Okay.
Hi, yes.
So the mentality, why you could not stent? I mean, stent was invented because of dissection and abrupt closure. So your point is, without having randomized clinical trial demonstrating it's safe, what is the issue of stenting a left main toward LED? We have more than 100,000 patients treated and they're fine. So the mentality. So why do you think that you don't have to stent and dissected ostial left anterior descending artery and left main? Which is the rationale, because I'm missing the rationale.
So to my mind, the question is the same, whatever vessel you're treating. It's either a vessel-threatening dissection and needs to be stented, or it doesn't. There is no good data out there showing a prognostic benefit of routine stenting in all of your angioplasty. Stents were only invented for the reasons that you just said, for vessel-threatening dissection. When you take those patients out of the equation, there is no prognostic benefit, but there is an attrition rate forever of having a stent in that vessel.
Yeah, but they were invented also for restenosis, because balloon had 50% of restenosis and there was a decrease in restenosis. So it was invented for two reasons, for abrupt closure and decreased restenosis, and there is no data so far demonstrating that not stenting is even equivalent to that. So we need data, that's all the point. Otherwise anything is done is anecdotal and not based on
That's what all the RCTs
evidence.
are showing you currently, is that there is no difference in restenosis rate in de novo DCB work between stenting and DCBs.
You don't have any randomized clinical trial on left main on that. Where is the randomized clinical trial?
But you don't actually have a randomized clinical trial of stents against anything in the left main stem.
Because this is not ethical. Why you should do that? Why you have to put an armful to a patient with a technology that has been demonstrated to be safe?
You have nothing to compare it to.
Yeah, let's see the randomized clinical trial, then we can talk.
Our data of left main stem work, a bit like that cohort I just showed you of bifurcations.
I think we can organize a match outside.
Okay. The last comment. So in our left main stem cohort, between DCB only and stent only, there is no difference in outcomes, but numerically the stent arm does worse in every single outcome, but not statistically.
Thank you so much. I would like to invite Bruno Scheller. We'll talk about practical case-based approach for bifurcation.
Thank you very much for the invitation as an alien here in the stent bifurcation club. This does not work. No drugs. So from the point of a DCB protagonist, we have proposed this algorithm which is called DCB only. Focus is lesion preparation, and the goal of your lesion preparation is to achieve an acceptable result, not a stent-like result, but lesion preparation an acceptable result. Acceptable means the absence of a flow-limiting dissection. This means type A and B are fine, and maybe some type C dissections because it's not the same always. And we proposed a maximum diameter stenosis of 30% you should achieve. So that's the goal. If you do not achieve this, then the recommendation is to use a metallic drug-eluting stent. If you achieve this, you do not have to implant a stent and can use the DCB for local drug delivery. And this basic principle could also apply to bifurcations. We have different scenarios. The first one is the hybrid or blended approach with DS in the main branch and DCB in the side branch. This has been discussed before. The more puristic concept, which I will refer to, is the leaving nothing behind concept, which means we have to prepare both branches, the side branch and the main branch. And then if you fulfill the criteria of an acceptable result, then you can use for this specific branch DCB only for local drug delivery. If you do not fulfill the criteria, then you have to stent it. And then we have a very simple approach, which has been also discussed before, is for smaller side branches, you treat only the main branch with DCB, and you have this effect of improvement of the ostium of the side branch over time. So what do we gain when not implanting stents? Number one, we gain vasomotion. This has been shown in 2 randomized trials. One of these is here. And this is data from Franz and our group. We see lumen enlargement, typically at 4 months. This means you do not need a stent-like result at the end of your procedure, but you can expect an improvement of your lumen over time. And that's the basic principle. Don't do kissing DCB. You see, there are 2 reasons. Number one, the first balloon you bring in is too long in blood, and you lose drug when being in blood with DCB. And it's a geometrical consideration. You have only limited contact to the vessel wall. The majority of the surface of your balloons has no contact with the vessel wall, and therefore you have very limited drug transfer, and therefore DCB should only be used sequentially, but not at the same time as a kissing procedure. So this is a case. Can you start it, please? Because I have no possibility to do this. Can you move start the movie, please? Yeah, you can see this is a bifurcation we did years ago in the PEPGARD BIF trial. First predilatation of the main branch of the circumflex, then there was carina shift. When treated the posterolateral branch, origin with a 3.015 paclitaxel-coated balloon, and then the main circ with a 3.020. And this was again the initial finding, and this was the primary result. So this is not a stent-like result. We have in the main part, we have haziness. We have not the perfect lumen gain, but we have a good flow, and therefore this patient left the table with this finding, which you can see again on the left side. And here you can see the result after 6 months. The dissection has healed, and the lumen has improved, and this is without stenting, and that's what we typically see. In this specific case, we also looked with IVUS at follow-up angiography, and interestingly, the area treated with the DCB only had more than 50% less plaque area than the areas before and after this treated area. Another example, a few weeks ago, a younger colleague of mine did it when being on call. This patient presented with non-ST elevation myocardial infarction due to this Ledi diagonal branch bifurcation. First step was predilating the side branch with 2.5 515 millimeter balloon. So this was the result after the pre-dilatation. This is according to our criteria an acceptable result. Therefore, treatment with a 2.515 millimeter paclitaxel coated balloon. This was the result after DCB, good flow still, a little bit dissection, but not flow limiting, so you can leave it. Then pre-dilatation of the main branch with a 3015. This was the result, also fine. And then using a 3.520 paclitaxel coated balloon. And this was the final result. This is a very simple procedure. It's done in 15 minutes. And you can see this is an acceptable result with good flow, and there's no need for stenting in this situation. Another case, a trifurcation in the right coronary artery. Again, after pre-dilatation, sequential use of 3 paclitaxel-coated balloons in all 3 directions. This was the initial result, looks good with some dissection, and this is 13 months later. Dissection has healed and lumen has improved. The other option has been shown before, so I do not have to go into detail. The origin of the side branch is improving, and this is an example, not exactly looking at this, but shows you the effect of treatment in the main branch to the side branch. This was this ostial circ with the intermediate branch. After lesion preparation, paclitaxel-coated balloon 3015 was inflated from the left main to the main circ, but not to the intermediate branch. This had only POBA, so this was the result, and there was some carina shift, so the left main to the LED was also treated with a DCB, and this was the initial result, and as you can see, especially the origin of the intermediate branch does not look that good, and this patient came recently 5 years later for another angio, and as you can see, there is no stenosis anymore in the ostium of this intermediate branch, and the ostial circumflex also looks good. So this is already my conclusion. DCB and bifurcations, lesion preparation is the first most important step, and it should include in this strategy the side branch if necessary. We have different scenario. The blended approach has been discussed with the stent in the main branch. And I personally prefer the more puristic approach, lesion prep in both branches, and then accordingly to the recommendations of the DCB-only concept, use stents if you have no acceptable result, otherwise use only the DCB, independent if it's the main or the side branch. And for smaller side branch, there could be the simple approach with using only a DCB treatment in the main branch. Thank you very much.
Thank you so much. Just a couple very rapid, brief questions. Gentleman there.
Principle for the stent, or the concept of the stents, is to avoid the recoils. So how can you guarantee the recoil will not happen 2 to 3 days, months later after the procedure, especially if the case with patient presented with acute myocardial infarction? So I can accept the DCB and side branch in in-stent restenosis, but in patient with acute myocardial infarction, how can to avoid the recoil? And how can you guarantee the recoil will not happen, all thrombosis again will not happen?
I disagree a little bit. In my opinion, the issue of acute myocardial infarction is sometimes that you underestimate the real vessel size. And therefore, you sometimes implant too small stents. If you use a DCB, you can use the smaller size, but you do not have the issue that then there is no remodeling anymore possible if you have undersized your stent, for example.
So one of the challenging issues in acute coronary syndromes is the plaque shifting on bifurcation. When you have a significant compromised side branch, what will be the next step?
You mean after treating the main branch?
Yes, yes.
Yeah. Then you have the option to do a kissing with uncoated balloons.
You cannot avoid kissing.
It depends on the result. I mean, the experience is that the side branch gets better over time. And this means you can accept in this situation not a recommended maximum 30% we propose, but it's only fine if you have the 50% stenosis. It will look better over time.
Yeah, but after single inflation, I mean singular inflation, side branch, main vessel, if you will have shifting, you can go with kissing without fearing that will not be effective.
Why?
Because you have already delivered your drug by inflating the drug-eluting balloon separately in side branch and main vessel.
Yeah, but
then if you have some compromise, you can go for kissing. Why not?
Why? It's no problem to do post-dilatation. But the point is, if you do not stent, you do not change the natural anatomy that way. And therefore, the need for kissing is much less frequent than if you stent in bifurcations.
Okay, I have one question. Can I? The left main bifurcation and other bifurcations are a little bit different, the basic size and angle. So is there a difference that to prepare before the DCB, the balloon size, the balloon selection, and the pressure? Is there anything?
Yeah, very important point. I disagree a little bit with Simon with respect to left main. If you have ostial left main disease, you need a stent, in my opinion, because aorto-ostial disease requires stenting. We can start talking about DCB distal from the ostium of the left main. For distal left main, it's fine, but if you have ostial left main disease, you need stenting. If you go more downstream, then there is no real need for stenting if you have an acceptable pre-dilatation result.
I have one question.
Very short.
A very short question over here. There's one situation where placing a stent is always very worrisome for me. That is in cardiogenic shock, because even a 275 stent in the proximal left main looks like it's enormous. Do you have any experience? Obviously, there are no data, but do you have any experience in drug-coating balloons for cardiogenic shock?
Very important point. In cardiogenic shock, you have excessive catechomers in your body. Everything is narrowed. If you implant stent, you induce additional spasm frequently, and that's of course a situation where I only try to do balloon angioplasty, and if I have flow, only if I good flow. If I have good flow, then I use DCB in this situation. But it's a rare event.
Thank you so much. We have to move on. And so I present Dr. Hildick-Smith about protocol for EBC DCB study.
Okay, there aren't any slides, so I'm afraid you'll have to look at me. So this is a good session, isn't it? It's reminiscent of all those sessions 20 years ago when there was no data and everyone had passionately held beliefs. And there were some quite strong exchanges at times in those meetings. So I'm going to give you a tiny bit of background to what my feeling is about this, and then present a brief protocol for a trial that we are looking for support from you to do for the EBC, drug-coated balloons in bifurcation therapy. So I'll just take you back to, how come we got to stenting in the LAD diagonal? It's always LAD diagonal, and how that initiated the bifurcation club. Because of course, once you put the stent across the side vessel, you've suddenly got a problem. There's a mesh there. Do we have to open the mesh? If we have to open the mesh, where do we go across? Can we rewire behind the stent? So that's the pot. So we did pot, suddenly we've got kissing, we've got position of recrossing, got use or no use of IVUS. So that's where everything has been for the last 15 years or more. And that's where all the energy has been. But, for me, and clearly for some people who've been doing this for many years successfully, quietly, there's a nagging doubt. And that is that although stents are great, and there are certain circumstances, a bit like the one that was shown on an angiogram recently, where a stent is definitely a go-to therapy, nonetheless, there are problems with stents. It's not a free hit. Once you implant a stent, you can't take it out. And there is a price to be paid for that stent. And certainly my experience personally in the catheter lab is that whereas we used to think that the late stent thrombosis was a feature of, oh, that's Taxus and Cypher stents, it doesn't really happen anymore. That's not right. It's not right. They do come back. And sometimes it's 5 years, it's 8 years, it's 10 years. But you see someone come back with either acute, very late, or acute on chronic, very late stent thrombosis. And you've got a real problem to deal with then, with perhaps a long stented segment, which has become rigid, perhaps a bit calcified, can be very difficult then to treat. How do you treat that successfully for the long term for that patient? So that was my personal experience of this nagging down. That these things do come back. There is, you know, it's as if the clock was just moved forward by having drug-eluting rather than bare metal stents. There's still a problem here. And then I was influenced by Greg Stone's paper about the attrition rate that you can see when you look at prospectively followed stent groups over long periods of time. You can argue about what the percent rate is. Is it 0.5? Is it 0.7? Is it 1? But it's a percent rate. And there is attrition over time with the implantation of a stent. And as I say, once you put the stent in, you can't take it out. It's a permanent inflammatory nidus. Okay, for 99% of people, maybe it's okay per year, but for 1% it isn't. So, and at the same time, there was interesting data coming out. You know, I used to think, drug-coated balloon, really? Are you serious? I mean, we've got stents. Look how they're fantastic. Look how amazing the stents are. But actually, slowly, personally, I changed my view and thought, well, you know, there is data coming out saying, I don't understand it, but that even the prognosis for these patients might be better. And this wasn't just one group banging at the same time. It was coming from different areas. I think ISAR Desire, the Norwich data, some German data, all hinting there could even be a prognostic benefit here. And of course, intuitively, if you could make sure that you didn't get acute acute vessel closure, and if you could make sure that you didn't get restenosis in the vessel, doing a procedure where you actually don't leave a permanent implant is an excellent intuitive strategy, just as, and this is a drum I have been banging for a long time, just as using one stent rather than two, for example, could be potentially a superior outcome for the patient. And then if we look at it from a slightly different perspective, you know, we all face this problem day in, day out. Oh, you know, that patient you put a stent in, they've got to have a hip replacement. And you go, oh God, you know, they're on a Pixaban for their AF and they've got clopidogrel. And if we withdraw things, they'll get stent thrombosis. And we all see cases coming back to the lab, stent thrombosis after the stupid surgeon stopped all their antiplatelets, blah, blah, blah. You know, this is a serious problem, which we can't get around. We have to sometimes say, oh, well, you're going to have to stop some medicine and, you know, take a risk. Again, that could be something that we don't have to face, at least nearly quite so much, with balloon therapies which don't leave a permanent implant. So with that background, I'd like to suggest a trial for you all. We've been talking about this in little groups for some time, and the trial, it's sort of, it's a bit of a tongue twister, sort of EBC, DCB. You'll have to get your tongue around that one. And it would be a trial of, again, fundamentally think of it as LAD diagonal, because 80% of them will be. It will be 111 or 011 lesions, non-left main. It will be obviously patients who require intervention based on ischemic criteria. Could be acute, could be chronic. There will be two groups. One is the standard provisional stepwise T strategy, which we all know and love. And the other one is a pure drug-coated balloon therapy. Now, the approach for this trial would be just as you suggested, pre-dilatation first, preparation, however you like, rotablation, shockwave, simple balloon, cutting balloon, to the main vessel, followed by, if the result is good or adequately good, randomization. After that, provisional T, you know the drill. In the drug-coated balloon group, it would be main side, side main. So having prepared the main vessel, the side vessel would then be prepared with simple balloon, then a drug-coated balloon, and then you'd come back to drug-coated balloon in the main vessel. And a bit like the example that Bruno showed us, we could end up in this situation having something of a paradigm shift. I rather hate that expression because it's used so often, but actually this really would be. I mean, it's a bold strategy. Some people won't necessarily take to it, and we've already had discussions this morning where people have expressed reluctance at treating the proximal LAD like this, but I think actually if you start doing it, we've been in the solutions study that Peter O'Cade is leading for the UK, and Simon mentioned, and actually the more you do this, the more you realize what can be done and what can safely be left. So as the music's playing, I'm going to stop there. Obviously there's finessing of the protocol to be done, but that's the bare bones of it, and I'd like to open it now for discussion.
Thank you so much. So, what do we have to do? Please.
Probably not, simply because it will be different in different geographies, and as we found with EBC main, where we wanted to include randomization for imaging but couldn't, some countries have it reimbursed, some countries don't. We will artificially limit what we can do if we include imaging, so probably not. Yes, again, there will be cost implications. I mean, obviously it'd be great to do imaging and physiology, but cost and time implications may prove tricky.
After treating the main branch and then the side ventral with the DCB, you won't recommend a kissing balloon to optimize the result?
No.
David, thank you very much for this excellent talk. I think it's very important to emphasize why we need to do a trial against stents, and that stent is not the final solution. I think there have been two errors around in this discussion today. One is late recoil. There's nothing like late recoil. There might be some vasospasm around this area, but a late recoil after 2 or 3 days, this is a thing that doesn't happen. And the other thing is, if you don't have a carina shift with DCB only, you might have some plug shift, but this is an open plug, and an open plug will heal in any way. Any plug that is opened up, that heals. So we don't have to worry about this if we don't have an acutely impaired flow. And this is the only point that have to be looked at.
Great,
David,
thank you.
Dave, so fantastic proposal. So in inclusion criteria, you said 111. So is there any criteria for side branch disease? Like it should be complex stuff because you will be doing T-stenting in the other group. So it should be more than 10 millimeter, less than 10
We
millimeter.
can finesse that. It may be that we choose less than 10 millimeters. Maybe.
And is there an option of not doing T in the other arm?
Sure,
T-stent?
no, it's provisional.
Provisional
It's provisional
or T?
to mandatory kissing because it's 111.
And then T if required.
T if necessary, rarely.
Dave.
No, the issue, I would...
Please, there.
Just a couple of quick questions, Dave. Brilliant presentation, great design. In terms of numbers, what sort of numbers do you think? And the second question, do you think we should have 3 arms? Do you think we should compare paclitaxel and limus? And I'm in, by the way.
Yeah, excellent. Perfect. Thank you very much. You're signed up. I don't think we can have 3 arms. I mean, practically speaking, if it was funded by a neutral body, that would be great, but I don't think we'll be able to do that. I think probably we're looking at something like 800 patients, but the actual calculations are a little bit difficult to make. Yeah.
So any other proposal? Other item?
Honestly, I would take out proximal LAD, that's prognostic vessel, and I would concentrate maybe to mid-distal LAD and diagonal and RCA or obtuse marginal. Take out the prognostic, go in the vessel that are done because of symptom relief, not for prognosis.
Sure. We won't do that. We won't do that. But thank you for the
No, I mean, that's the idea. We want, it's a decision.
If
I have a remark that has nothing to see with the protocol. For the specialist, do you think that the kind of what you put on the wall may have some structural effect? You say yes. You think so? May I explain that maybe with this DCB we are also solving the problem of small dissections. What do you think about it? If it's not true, why not? I don't know if the companies are here. Why not thinking about that? Which will be maybe for the future an improved solution.
Professor Kleber?
Franz.
I mean, any dissection which is not compromising flow leads to an improvement in prognosis and vessel size. This we know from Andreas Grünzig. Yeah, this is very old. I think in addition we have a drug, at least paclitaxel as a drug, which causes further increase in vessel size within the 2-3 months area. So this is a change we do know. And secondly, we know from the SCAR registry from Venezianos that the long prognosis is better without a stent than is better with the DCB than with a stent. So I think we don't have to address small vessels. I think we have to address any vessels if we do such a study. And if we go beyond the first 24 hours or 48 hours, we don't have any further risky time period.
Okay, we think I think that we can all think about during these couple days, and then having some kind of final.
Perfect. Thank you very much.
Okay.
I'll be around. Everybody could come and chat. Thank you.